and we are needing to get all of these videos recorded ASAP. And listen to them tomorrow, because what's the whole point of recording them the next day when you don't even have massages the next day? You know what I mean? Anyway, this is chapter 18. Let's go.
Chapter 18 goes over the nursing care of a newborn. I'll admit, I was surprised to see or learn how many people have either never held a newborn or don't feel comfortable holding a newborn or caring for a newborn. And mother's intuition doesn't necessarily cover all the details. So parents really watch the nurse interacting with the newborn to learn how to do that and how to look for it. So your book kind of starts out with what to look for if there's a problem, which I kind of like, because it's, a lot of times with our newborns, you don't really know what you should be looking for. And most of the newborns that you're going to see will be healthy and adapting well to life outside of the womb. So this would probably be the most important signs to be looking for when you're doing your assessment. So the first would be, and most of these, all of these, are respiratory complaints. So the first is nasal flaring. This is when the nares of the nose actually flare outward. This would be a sign of respiratory difficulty or distress in the newborn. Chest retractions or substernal retractions. So that's when the skin will kind of...
Hold on. I'm wondering if we can go faster. Okay, we can. Okay.
Retract in underneath the ribs or in between the ribs, like they're sucking in. There's a sucking in. So that's retractions, and retractions are never normal in newborn. And then the third, so the top 3 signs of respiratory distress will be nasal flaring, chest retractions, and then grunting. So grunting is specifically when they're exhaling. They do kind of this little noise, and it almost sounds cute. They just do and so that would be just a little bit more of a grunting. It's a forced respiration, and it's demonstrating labored breathing. So it just means they're kind of working to breathe a little bit. So grunting, flaring, and retractions are all early signs of respiratory distress. A late sign that a newborn is having respiratory distress and difficulty breathing is cyanosis, when, the lips turn blue, the face turns blue, and like that. That's a very late sign. Or a flaccid body posture. So weak, not active, just kind of lethargic. So upon assessment, you're going to identify if there's abnormal breath sounds. You might hear rhonchi or fluid, wet sounds. And that's not normal. We want to clear that out if that's the case. You can also have an abnormal respiratory rate, so tachypnea. When the respiratory rate is too fast, that can indicate respiratory distress in the newborn. And then abnormal heart rate, tachycardia, that can be present when the baby's working hard to breathe. If the abnormal newborn size is if you have premature babies or even macrostomach babies, like big babies, they're going to be at a little bit more of an increased risk for respiratory distress.
I did not know that. That both the premature baby and the macrosomach baby we have to really look out for. And she's saying that, of course, for all of these problems, it's respiratory problems. And you have nasal flaring, chest retractions, grunting on exhalation. That may be labored breathing, generalized cyanosis, weak body posture or flaccid body posture, abnormal breath sounds, like crackles.
So an APGAR score, an APGAR is a quick test that we do. We perform it at the first minute of life and the 5th minute of life. That first minute kind of tells us how the baby tolerated birth, the birthing process, and the 5-minute APGAR will tell us how the baby's handling life outside of the womb. If the first minute and the 5-minute APGAR are 6 or less, so this is base out of 10, you get 10 points total. If they're 6 or less, then we're going to do a 10-minute APGAR also, just to give them a little bit more time to transition. I'll talk about APGAR in the next few slides. This is kind of an overview, actually, of what we're going to be talking about in the next few slides. So initial newborn assessments, we'll do the APGAR at 1 minute and 5 minute. We'll do a length and a weight. We're going to do heart rate, respiratory rate, and temperature. And then we're going to talk about this, but this physical maturity and the neuromuscular maturity, that's called a Ballard scale. We don't do this routinely unless we don't really know the gestational age of the baby. So we'll talk about that. And then we'll just talk about gestational age. So let's go into APGAR first. So APGAR is that first score, 1 minute and 5 minutes of life. We base it off of 5 categories. So appearance, pulse, grimace, and this is like reflex irritability, how they react, activity, and respirations. So your first one would be color. That's is if, and there's 2 points for each category, right? So color would be if they're pink, and if they're pink uniformly, right? It's normal, very, very normal for babies to have what's called acrocyanosis, and that is like blue or purple hands and feet that typically lasts about 24 hours. It's rare for a baby to get 10, like a score of 10, 2 in each category, because the greater majority of babies will have acrocyanosis. So we take off 1 for color, 1 point for color. Pulse would be heart rate. So if my heart rate is over 100 beats per minute, the patient will get 2 points.
Okay, so what we've been told, or I have been told, is 110 and 160. Even I heard 120 to 160, but she's saying that it can get a score of 2 on the APGAR score if it's 100, at least 100.
If it's less than 100 beats per minute, it's going to get 1 point, and if there's no heart rate, there would be 0 points. Grimace is the G. Sometimes this is called reflex irritability. This would be when you give stimuli. Is there prompt response, right? So like a pain, like sometimes we'll flick the foot, any kind of like irritated or painful stimuli, does the baby respond? So a prompt response would be 2 points, a minimal response, like a weak response, would be 1 point, and just no response or floppy would be 0 points. Next up is activity. This is how active is the baby moving. So we expect that their arms and legs will kind of move around a little bit just voluntarily. And so an active muscle tone, this would be 2 points. Flexed arms and legs, but not too active, not a lot of movement, would be 1. And then just a flaccid, floppy baby, that would be 0. And then respirations is the R, respiratory. So do we have a strong cry? And yeah, really we just base this off of cry. Like a strong, active cry would be a 2. Slow or irregular breaths, or like that weak kind of grunting, that's going to be a 1. And then no respirations would be a 0. So typically your most common APGARs that you're going to see would be 8 and 9, like 8 at 1 minute and 9 at 5 minutes. Typically we always get a point off for color, and then there might be a point off for respirations or for grimace initially, and then they transition to life within that 5 minutes, and they're usually up and going and doing great. Okay, and this is just a table in your book that kind of goes over what we talked about here. These are your standard newborn vital signs. These are normal findings that we expect to see. Temperature, you can just read them here. But heart rate, again, 110 to 160. Respirations, 30 to 60. And then blood pressure, let's talk about that for a minute. So blood pressure is not routinely done on our newborns. We do it one time to check for like heart abnormalities. But typically after that, blood pressure isn't...
blood pressure
is one of the last vital signs to decrease. Whereas in an adult, blood pressure is one of the first vital signs. If someone's in kind of distress, their blood pressure will usually start to drop. Whereas in children under 3, it's that last thing to go. So we don't do routine blood pressures on our babies. We'll do an initial blood pressure to check for any kind of heart deformities. But after that, when we ask you to go do newborn vitals, all we're looking for is temperature, heart rate, and respirations, not blood pressure. And then the gestational age, these are just kind of terms, definitions and terms that we use for gestational age. So when the baby is born, we want to make sure, remember gestational age is, a guesstimate really. So we want to make sure that, that the baby is like where we think the baby should be. So we'll do different assessments, but I don't like the way they do this, because preterm is anything before 37 weeks. That's true. But term then should be 37 weeks to 40 weeks or 42 weeks. Post-term usually is 40 to 42 weeks, and then post-dates is after 42 weeks. And then SGA is small for gestational age. AGA is appropriate for gestational age, and LGA is large for gestational age. Typically, by definition, small for gestational age would be less than 5 pounds, 5 ounces, and large would be more than 8 pounds, 8 ounces. So this is what we call the Ballard scale. This is more of a NICU thing. We don't really do this routinely in labor and delivery unless we get a mom that comes in that maybe hasn't had any prenatal care. Like we don't know at all what is going on. The neonatologist will do this and go over everything. So we'll go through it real quick, but they kind of assess physical maturity and then neuromuscular maturity here. So they go over a few things here, but skin texture, they're going to assess for skin turgor. Skin can appear blotchy or mottled. Acrocyanosis can be present. Remember that. That's a normal finding. The skin can be covered in vernix, which is like a cream cheese looking substance, like a thick white substance. It protects the skin from just being in that fluid environment, amniotic fluid. We'll also go over different common skin things that come in a few more slides. But skin texture in a premature infant can look almost transparent or just really, really super thin skin. And then a post-term baby can look like just kind of a wrinkly old person. So they can have sagging skin, they can have lots of deep wrinkles, and they can have peeling skin. Lanugo, this is the hair that's spread over the body. A preterm baby is going to have more lanugo than a post-term. So you can kind of see the different things here, but mostly bald would be term. And then if there's an abundant amount of lanugo, that's the one. Plantar creases, that's the foot. So you can kind of see here, I don't know if you get a good visual here, but a preterm foot is going to look more shiny and smooth. They're not going to have very many creases. This would be pretty much a term, and this would be more post-dates. They get more deep crevices that go in there. So the more term they are, the deeper the crevices in their foot. Breast tissues, so the more term they are, they're going to have more buds, like palpable breast buds, whereas the more preterm they are, they won't have that. Eyes and ears, so really preterm babies, typically before they're viable, their eyes are still fused, and their ears might lack cartilage, so their eyes aren't going to be able to open initially. And then post-term babies and term babies, their eyes will open and their ears will have cartilage. So we do this. This is kind of our normal health assessment. Our physical assessment, we look at these things. And then the genitals. In term infants, the labia majora covers the labia minora and clitoris and introitus, whereas in a premature newborn baby girl, they're going to have a really prominent clitoris and like a small labia that doesn't cover. In males, the urinary meatus should be located at the tip of the penis and the scrotum. The scrotum should be large and rugated in term neonates, and then both testes have descended and they're palpable in the scrotum. In preterm, the testes might not have dropped yet. And then the neuromuscular part of the Ballard scale. For posture, that's like we observe the flexion of the infant's arms and legs when the infant's quiet and supine. So this would be less term, and then this would be more term and more appropriate. A square window is we apply gentle pressure using our index, our second and third fingers to the back of the infant's hand while supporting the wrist, and what kind of flexion happens. Arm recoil, we flex and extend the infant's arms and observe the rate and strength of the recoil when the infant is in supine position. Popliteal angle, we flex the infant's thigh to the abdomen, extend the infant's knee, and measure the angle behind the knee. And then the scarf sign, we move the infant's arm across the body and observe to the point to which the elbow moves easily in relation to midline. And then heel to ears, when the infant's supine, we grasp the infant's foot and pull it towards the ear the same side using minimal force. And we observe the popliteal angle of that. So again, the doctors will do this quickly, routinely, just to assure that the baby is the gestational age that we think it should be. And then these are just kind of the quick, immediate newborn interventions that we're going to do. So we want to really just maintain airway patency. We typically do that mainly through bulb suction, using that bulb syringe and suctioning. We're going to talk about this later, but we ensure proper identification. We're going to make sure that mom, support person, and baby all have the same matching ID bands. Like there's a number on these bands. So this is different than mom's hospital admission band with her MR number. This is the newborn band. So baby will have one on the wrist and the ankle, and then mom and support person will have one, and all the numbers match. And so we make sure whenever we separate baby from mom that we're checking the number when we leave the room, and then we check it again when we bring the baby back into the room to make sure we have right baby to right mom. We're going to give meds unless parents refuse, but we're going to give vitamin K. This is always given in the left thigh. And we're going to give erythromycin eye ointment in the eye as a prophylactic antibiotic to prevent against gonorrhea and chlamydia. Vitamin K helps with the baby's blood clotting, since they're not born with clotting factors. And then we're going to maintain thermoregulation. So we're going to keep that baby under the warmer or skin to skin with mom, or if not, they're going to be swaddled with a hat. We're going to make sure we're maintaining our baby's temperature.
Okay, we are done with the newborn assessment.